team is from Osmania Medical College, comprising Zaara, Harmain, and Zubia, Menaz, Ahmed.
Good morning everyone, I am Zubia and this is my friend Zaara. We are from Osmania Medical College. This is the case sheet of a patient. A 13-year-old boy, a resident of Hyderabad, was brought to Osmania General Hospital with the chief complaint of blood and urine for the last 1 day. The history of present illness: patient was apparently asymptomatic 1 day back when he developed hematuria, which was throughout the flow, acute in onset, with passage of clots in urine. There's no history of fever, no history of any pain, abdomen, nausea, vomiting, no history of burning, micturition and other bleeding manifestations. Past history: patient is a known case of epilepsy since 3 years of age and he's on anti-epileptic medication since then. Not a known case of chronic kidney disease or diabetes mellitus. Personal history: everything was normal, nothing significant. Family history: not significant. On general examination, patient is conscious, coherent, moderately built and nourished. There's no pallor, no icterus, no cyanosis, clubbing, no lymphadenopathy and no edema. Neurocutaneous markers seen were multiple papular lesions over both the cheeks, chin and neck. Fibrous plaques were present on the forehead. This is the patient photograph. Slight elevated lesions were present over the lumbosacral region and hypopigmented macules over the lower back. This is the photo. Vitals were all normal. So on central nervous system examination, patient is right-handed. He was mentally retarded, could only speak small sentences. All cranial nerves were all normal. Motor system, bulk of the muscle, tone, reflexes were all normal. Cerebellar system, sensory system, all were normal. No meningeal signs present, no skull and spine were normal. There are no peripheral nerve thickenings. Cardiovascular system, respiratory system, gastrointestinal system were all normal. The provisional given was tuberous sclerosis. Differentials for this case was periventricular nodular heterotropia, MEN1 syndrome, Bird-Hogg-Dubé syndrome, polycystic kidney disease. Investigations done were complete blood picture, everything was normal. Random blood sugar, renal function tests were all normal. On urine examination, RBCs were seen on microscopy, ECG was normal. The ultrasound was done. In the left kidney, a hypoechoic mass was detected. CT was advised. According to the CT scan, a lobulated mass was seen in the left kidney, suggestive of renal angiomyolipoma. This is a picture of the CT scan. CT brain was advised, and in the CT brain, multiple calcified nodules are seen in subependymal region, and multiple hypodense lesions in cortical and subcortical white matter, suggestive of tumors. Diagnosis, which was done after this, was Border disease or tuberous sclerosis. The management done for this case is he's on anti-epileptic medication since 3 years of age and lifelong continued treatment. Surgery was planned for this case for surgical excision of the renal angiomyolipoma to control hematuria. Thank you.
Whether it was a normal delivery or a complicated labor, and most important milestones, mental and physical milestones were not mentioned. That is very important. Though you said mentally retarded, when did this develop? Okay, when did the parents notice? These 2 points are very important in this case. Pedigree chart should always accompany any kind of these cases. Okay. What is the name for the CT scan appearance of tuberous sclerosis? Description. There is a description to the CT brain. No, you do not. That is called a railroad appearance. Railroad appearance. So that is the name. See, the people give fancy names to everything. Okay. And when did you see this case? When was this?
It was a last year's case, ma'am.
Okay.
The patient did turn up for follow-up again.
Did you change the anti-epileptic medication?
Sorry, ma'am?
Anti-epileptic medication, phenytoin. Did they change the medication? It was being continued. Okay, good, please.
During the examination, we reported as red urine, that is macroscopic image.
Microscopic image.
Only microscopic cancer. This is red urine. If hemoglobin is normal, okay, that is, it did not do significant. Right? So what else can be done? He continues to breathe. Continues to breathe, what do you do? What do you do?
Sir, the only management probably that could be done for this is surgical excision of the mass to control hematuria.
Short of that?
To control the tumor, mTOR inhibitors can be given, sirolimus, SCLEROSIS, to control the growth of tumor.
The intervention radiologist.
Renal artery embolization.
So that can be done.
Yes, that can be done.
Major surgeries, not indicated or not active.
Embolization.
Sometimes we do the Harmain biopsy in a situation to find out really safe one because they don't diagnose it. All the pictures are there. Histopathology is not. Generally don't do. When they necessary, we have to operate to evaluate it. Very good chart in all the genetics, other presenters also. Make it habit or genetic disorder. Congenital disorders also. Congenital doesn't mean genetic. You should draw a chart. And who is the provide and so on and so forth. All these things are time is because it's not government, the members of the family. Milestones are made of say metal retardant. No mention about the big.
My opinion about this is there are, mnemonics are there. Three is epiloia, SCLEROSIS, and skull findings. They have been not done. Skull X-ray was it taken? No. That should have been done. Rail track phenomena is usually present. Epileptic fits are also not there. They should have been present in TUBEROUS.
Sir, that was in the past history, sir. The present problem was happening.
Better that you should have asked. The side of the photograph of the man also should have been depicted because there are the TUBEROUS. Where is the?
These are the adenomas.
We should have shown it with a fighter.
Sure. From the cursor there.
In our day, Dr. Kopachi Krishnamurthy was there from Vizag. He was very much emphatic about these 3-4 phenomena, these numerous sclerosis. And they are must. And of course, they are there. Epilepsy, is there any history of epilepsy?
Yes, sir. Since 3 years, since the age of 3 years, he is an epileptic. These are the Shagreen spasms and there's a hypopigmented area here, Ashley.
It is very not clear from here because I think
The light is not.
Otherwise, I think it is dark.
Yes, sir. It was clear.
One of the presenters previous I can't find out. They put a European picture. You should not a European lady's picture. Patient should come. All the presenters acknowledge the patient and relatives. He is retarded, so consent cannot be given by him. Say acknowledge. Acknowledge teachers, friends, and most important, patient and relatives. You should carry first. We acknowledge the cooperation of patient and relatives. Meeting us with the
X-ray of skull was not taken.
No, sir, it was not.
It should have been taken because the phenomena, rail track phenomena, usually they say 50 to 60% of the people it is present.
Nowadays, CT has witnessed the plain medicos. So, orthopedic post-injury, not medicos. Right.
Thank you, sir. Thank you.
And your
Whether it was a normal delivery or a complicated labor, and most important milestones, mental and physical milestones were not mentioned. That is very important. Though you said mentally retarded, when did this develop? Okay, when did the parents notice? These 2 points are very important in this case. Pedigree chart should always accompany any kind of these cases. Okay. tuberous sclerosis. Description. There is a description to the city, brain. No, you do not. That is called a railroad appearance. Railroad appearance. So that is the name. See, the people give fancy names to everything. And when did you see this case? When was this?
The last year's case, ma'am.
Okay.
The patient will turn up for follow-up again.
Did you change the anti-epileptic medication?
Sorry, ma'am?
Anti-epileptic medication, phenytoin. Did they change the
No.
medication? It was being continued. Okay, good case.
During examination, is reported as red urine, that is macroscopic image.
Microscopic image.
Only microscopic cancer. This is red urine. If hemoglobin is normal, okay, that is, it did not do significantly. Right? So what else can be done? He continues to breathe. Continues to do what will do? What will do?
Sir, the only management probably that could be done for this is surgical excision of the mass to control hematuria.
Short of the
To control the tumor, mTOR inhibitors can be given, sirolimus, to control the growth of tumor.
the intervention radiologist.
Renal embolization.
So that can be done.
Yes, that can be done.
Major surgeries, not indicated or not active.
Embolization.
Sometimes we do the main biopsy in a situation to find out really the same one because they don't diagnose it. All the pictures are there. Histopathology is not. Generally don't do. When they necessary, we have to operate to evaluate it. Very good chart in all the genetics, other presenters also. Make it habit or genetic disorder. Congenital disorders also. Congenital doesn't mean genetic. You should draw a chart. Who is the band and so on and so forth. All these things are time is the members of the family. Milestones are very much say metal retarded. No mention about the big.
My opinion about this is there are, mnemonics are there. Three is epiloia, SCLEROSIS, and skull findings. They have been not done. Skull X-ray was it taken? No. That should have been done. Rail track phenomena is usually present. Epileptic fits are also not there. They should have been present in tuberous sclerosis.
Sir, that was in the past history, sir. The present problem was happening.
Better that you should have asked. The side of the photograph of the man also should have been depicted because there are the tuberous. Where is the?
These are the
We should have shown it with a fighter.
Sure. From the cursor there.
In our days, Dr. Kopachi Krishnamurthy was there from Vizag. He was very much emphatic about these 3-4 phenomena, these tuberous sclerosis. And they are must. And of course, they are there. Epilepsy, is there any history of epilepsy?
Yes, sir. Since 3 years, since the age of 3 years, he is an epileptic. These are the Chagrins patterns and there's a hypopigmented area here, Ashley.
It is very not clear from here because I think the light.
The light is not.
Otherwise, I think it is dark.
Yes, sir. It is clear.
One of the presenters, previous, I can't find out. They put a European picture. You should not a European lady's picture. Patient is others. All the presenters acknowledge the patient and relatives. He is retarded, so consent cannot be given by him. Say, acknowledge. Ophthalmic teachers, friends, and most important, patient and relatives. You should carry first. We acknowledge the cooperation of patient and relatives. Meeting us to the
X-ray of skull was not taken.
No, sir, it was not.
It should have been taken because the phenomena, rail track phenomena, usually they say 50 to 60% of the people it is present.
Nowadays, CT has replaced the plain medicos. So, orthopedic post-injury, not medicos. Right.
Thank you, sir. Thank you.
Our last presenter for the day is P.V. Jaswita from Kaminini Institute of Medical Sciences, Narketpalli.
Good morning everyone, this is Jaswita from Kaminini Institute of Medical Sciences, Narketpalli, here to present a case on cardiac beriberi. It's often a misdiagnosis but a common problem. A 54-year male was brought to the casualty with the chief complaints of period edema since 2 days and shortness of breath since 1 day. Vitals on arrival were heart rate was 140 beats per minute, BP 80 by 40 mmHg, respiratory rate was 40 cycles per minute which was rapid and shallow. The patient was FFI with warm peripheries and SpO2 was 81% on lumen. On primary survey, the airway was patent and circulation was prolonged with capillary refill time greater than 3 seconds. Specific measures we took were, in view of severe respiratory distress, the patient was intubated with endotracheal tube and was connected to a ventilator. Oxygen supplementation was given. Injection sodium bicarbonate and injection noradrenaline were given. Vasopressin and human activate via syringe infusion pump were given. Insulin euglycemic therapy was administered. General measures were, rice tube was inserted, Foley's catheterization done. We monitored for ABP, heart rate, SpO2, respiratory rate and urine answer. History of presenting illness. The patient was apparently asymptomatic 2 days back, after which he developed fetal edema and shortness of breath 1 day later, associated with pain and right hypochondria. No history of chest pain, palpitation, syncope, fever and cough. Past history, there was no past medical history and no relevant surgical history. Comorbid conditions like hypertension, diabetes mellitus, tuberculosis and seizures were absent. No drug allergies present. Personal history. The patient is chronic alcoholic with a regular intake of 90 ml per day since 20 years. There is no significant family history. Secondary survey shows the patient is conscious, oriented in severe respiratory distress. The jugular venous pressure is elevated with bilateral carotid swelling. Heart sounds S1, S2 and S3 were heard and bilateral period edema present with bar of 5 to 5. Differential diagnosis. It may be right heart failure with cardiogenic shock, alcohol-induced cardiomyopathy leading to cardiac failure, alcohol-induced metabolic acidosis, sepsis leading to septic shock. Investigations we ordered were ABG analysis, ECG, 2D echo, leptospira antibodies, complete blood picture, complete urine examination, renal function test, liver function test and programming time, chest radiograph, ultrasound abdomen and blood and urine culture sensitivity. Liver function test shows the elevated liver enzymes and a fall in total proteins in albumin. Complete blood pressure gives an increase in total count and renal functions are deranged. ABG analysis indicates that there is severe primary metabolic acidosis with uncompensated respiratory alkalosis. ECG gives us a sinus tachycardia and right atrium and right ventricle are dilated in 2D echo. There is cardiomegaly on chest radiograph and ultrasound shows grade 2 fatty liver. Final diagnosis of problem-based approach. Right ventricular failure, severe metabolic acidosis, hepatic dysfunction, which may be due to the vitamin B1 deficiency leading to cardiac beriberi. The treatment we have given were injection imipenem, injection thiamine, etipamil, udilip, N-acetylcysteine, and iron, calcium, and multivitamin supplementations along with an antacid. The patient was sent for psychiatric counseling for de-addiction. Here comes the important part, the mechanism of the disease. Pyruvate, which is an end product of glycolysis, is converted into acetyl coenzyme A in the presence of TPP, that is the active form of thiamine pyrophosphate. And this acetyl coenzyme A enters the Krebs cycle for the production of energy molecules and ATP. In the absence or deficiency of thiamine, this process halted and the pyruvate gets converted into lactic acid, and with the accumulation of lactic acid, there is lactic acidosis or metabolic acidosis. When a patient comes to the casualty with neurological or cardiovascular symptoms, then we have to think about thiamine deficiency and very often. Thank you.
Thiamine deficiency patient has.
It may be dry very also, apart from.
Madam is a neurologist.
What other features you keep looking? You are sure that this is a very, very good. What are the other features of delivery other than heart? Other than heart, which other symptoms or signs are what other are?
We see for the neurological diagnosis.
What are they?
That is peripheral neuropathy, like mental and
Very, what are the symptoms? Neurological symptoms.
mental retardation, depression, ataxia.
Mental retardation. Huh? Do you call it retardation? What do you call it? We are concentrating only on the heart.
Encephalopathy, Wernicke's encephalopathy.
Yes.
And Korsakoff syndrome. Maybe something like that.
See, madam, confirmation comes for giving the treatment. Suppose we give whatever the B complex factors and variable B1 is given, the response is depicted in cardiology.
Yes, sir.
Otherwise, how can you say it is because of only very
What confirmation test? What confirmation test? You know, all of us treat like that. So no problem. Confirmation test. Even B12 deficiency, week work. A few hours will take a report. Iron will take. Whatever time it will. Other deficiencies don't do test. So friend is not this.
No, sir. No.
If all the labs, you are not in this country. Advanced country, then you do all this.
The symptoms are recovered after thiamine supplementation is.
The salary is asking that test. You mentioned,
Confirmation.
one confirmatory test.
Yeah, average glucose is a confirmation. Elevation. Something like that. In enzyme. What is driver?
Rivalry is a cerebral beriberi, where neurological symptoms are, we can see the neurological symptoms.
Is it reversible?
Up to
Very neurological
still.
syndrome. You already said Wernicke's encephalopathy and Korsakoff psychosis. It is not syndrome, Korsakoff psychosis.
Yes, ma'am.
Is it reversible or irreversible?
Up to some extent.
Which will remain? Wernicke's is treatable. Korsakoff's once it sets in, it is only partially recovered.
Liver enzymes are elevated, right?
Because there is liver dysfunction, sir.
You not answer. Why you are answering?
Liver enzyme.
Enzymes elevated because of that, right? It's simple. Is it due to heart failure?
Heart.
Is it due to alcohol?
Right heart liver. And Zaara is asking whether it is due to alcohol or whether it is secondary to heart failure. What is the reason here in this case?
Secondary to heart failure.
How do you differentiate them? Such point is that what parameters you look into the liver function test, which will give you the clue whether it is alcohol or whether it is cardiac. What is the difference?
How much of a thiamine is given? 390 after 11%. If we are exceeding, we don't give a
Initially 200 mg was given, sir. Later it was reduced to 100 mg.
only once a day. Don't project these charts. Like whatever. Thiamine, we complex all the cells, what cells. So you don't do 6,000 medicos. 110 milligrams every 8 hours also. And all of you don't mention creating the urine. Thiamine is everything here. What is the first one? Injection.
Independence.
We may not not a generic name. Usually with the brain name, the US design. One of us, shell cap, one brain, dynamic. See, generic and then brain name, all scientific presentation, only generic. What is one of us?
Iron supplementation.
What is the chemical?
Ferrocell.
Wait, it's not. What is increased concentration here?
Sir?
It's not increased. Actually, has hypertension.
Jugular pulse increase.
The concentration is low. Okay, otherwise you expect a high concentration. Gives a hint.
Thank you.